I only have a few disclosures and disclaimers like my teenagers when they come home. I would like to thank the AANS and the CNS CV, and particularly the endovascular group, because some of the information in here is from shared information that all of us have worked to put together. You know, I sort of, years ago when we started putting stroke programs together, it was a lot like this. You know, you're trying to establish a foothold somewhere where it's culturally difficult, it's logistically difficult, and you know, these two guys sort of saw that from the ground up. It is hard, and in the beginning, you know, it was hard and seemed to get better, but then seemed to get worse, actually. In 2013, March, the New England Journal of Medicine published 3 articles concurrently, and of course, the lay media hopped all over that. And things were looking a little bit grim. And of course, you know, many of our colleagues who never believed that we should have been going to the interventional suite, you know, said, yeah, obviously, you know, you guys have been doing it wrong forever. You know, we respectfully disagreed, but again, we really didn't have good studies to back us up at this point, did we? You know, we all had the belief that we were doing the right thing and we were running in here at all hours of the day and night, and now all of a sudden here came these 3 prospective, randomized, controlled trials that said we really didn't know what we were doing, and we really shouldn't be doing that and spending all this money to make no difference at all. So, you know, and this is kind of, you know, how it went for me. I literally was getting phone calls.
You want answers? I think I'm entitled. You want answers? I want the truth. You can't handle the truth.
So you pick who's who, but you know, that was kind of my life. And you know, I had put a stake in the ground, and I said, you know what? Stroke patients are a vulnerable population, and they need to be cared for. And many of my colleagues said, oh no, there's nothing to do. You know, maybe they get TPA, maybe they don't, but what you do doesn't work. And then, of course, I had 3 trials that said, gee, what I do doesn't work. So it was kind of scary. And so synthesis expansion was done in Europe, was done in Italy. Endovascular therapy, not superior to intravenous TPA. IMS-3 seemed like it was going on my entire adult life. Similar safety outcomes. No evidence of any functional difference in any of the patients. IV TPA versus IV TPA plus endovascular. Let's see, I think I should postpone the restart on my computer here. There we go. You guys might not be happy. MR rescue. Supposedly this looked at the penumbra, right? So one of the reasons we want to go and salvage these stroke patients in the interventional suite is perhaps there's some brain there that we can save and we can minimize their stroke. MR rescue came out and said, nope, favorable penumbral pattern, no difference between endovascular therapy and intravenous TPA. So if you were an interventional guy, you're sort of feeling like this. You know, here you'd got the watermelon out, you'd cut it all up, and you're like, man, what am I going to do? And this is really how it was. We were, you know, we all were sort of like, wow, this is a problem. But then again, we all have these cases day after day, week after week, right? So it's a 63-year-old guy who's part of our stroke network. And, you know, he came to one of our affiliate hospitals, and this guy got up in the morning, he was fine, got himself a bowl of cereal, cup of coffee, noticed that he dropped his spoon, couldn't hang on to his spoon. So like any guy, he used his other hand. And then his coffee came out of his mouth, and when his coffee came out of his mouth, he thought, well, you know, enough of this, can't get my caffeine, I better go to the hospital. So he went to the hospital and he got TPA and he didn't get any better. And he actually progressed, and he was shipped to us, and he went straight to the CT scanner for his perfusion. And you can appreciate, I think, many of you, that, you know, for us, this is reversible ischemia. You know, diminished blood flow, his mean transit time is up, but he's got retained blood volume. So we took him straight back to the cath lab, and this guy had a complete carotid occlusion, all right? We actually had to stent his carotid to get up into his head, which we did, and then little angioplasty. Here's his, once we cleared out his carotid, here's his supraclinoid carotid. For those of you who don't do this for a living, you know, there should be all kinds of stuff up here, which there wasn't. And, you know, again, like many of you, lots of the folks here, this is how we do this. We use a stent on a stick called a stent retriever. We deploy this within the segment with the clot, pull it out, and lo and behold, there you go. And now all of a sudden he's got flow up here. And this is actually what we pulled out. Yeah, 20, 30 years of Wendy's. And you know, this guy was on the table. We do these awake, like many of you probably do. And you know, he woke up and he lifted up, this was left side, he lifted up his right arm and he goes, "Thanks, man." And you know, for those of you who've worked in cath labs, you know how the cath lab nurses are kind of jaded and tough and, you know, grizzly, you know, and two of our cath lab nurses are like, "Oh my God, this is why we do this." And they started crying, and I'm like, remember that at 2 o'clock in the morning. Thank you very much. But anyway, so, you know, but that was him, and this was him the next morning. Normal perfusion in his brain. And this is him getting ready to be sent out of the unit the next morning with a hep block. And he went home the next day.
That's a side effect of the procedure.
Right. So, didn't want to be identified, you know. So anyway, that brings us to this. And this is kind of my take on a lot of prospective randomized trials. You know, doing the same thing over and over again and expecting different results. And it's actually one of the things I tried to teach Allie. When Allie first started, oh my God, same thing again and again and again. And one thing I like to do, and which one of you, when one of these guys left, they actually gave me a little booklet of my sayings to them. But yeah, I thought it was really clever, but so rude. But anyway, but you know, you really, sometimes you got to take a new approach. And one of the places we really failed in prospective randomized trials is we've never truly, until recently, run trials where we looked for the patients we actually treated, all right? We don't treat all comers in the cath lab. And so to take all comers and subject them to the cath lab or TPA really has this tremendous dilutional effect on the outcome. And so, again, and it brings up other questions, right? We have all these trials that show no benefit, and we're just not able to realize the full potential of these devices. And is there something we don't know? And I would argue that maybe, maybe not. This is actually from cardiology in the early 1990s in reference to coronary artery stenting, okay? And so history repeats itself, and interventional treatment of stroke really is just the same as what we've been through before with coronary artery stenting. And it's analogous to how many people would rather go and have open heart surgery when you could get a stent in your LAD and go home the next morning, okay? Versus being extubated the next morning and, you know, having a bit of an incision. So, again, think about where we've been. So in the 1970s, the first coronary balloon angioplasty was performed. And it was done in patients who were in extremis, all right? And the results were not very good, actually. There were tremendous reocclusion rates. The complication rates were 30 to 40%. And then when they got really good at it, the success rates were about 60 to 70%. And so in the mid-80s, this is where balloon angioplasty was, okay? And this was for subacute reocclusion right when the procedure was performed. And in 1987, because the restenosis rates in the successful group was as high as 50% after angioplasty, people began to think, well, maybe if we put a stent in, right? But there was a huge cultural barrier to get over with stents because the only thing stents had really been used for in the past, at least in the lab, was as a model to reproduce atherosclerotic disease. Because if you laid a couple stents in an animal's aorta, they actually got a stenosis, all right? And so there were people who believed that stents just couldn't work. And the first 5 or 6 cardiac trials seem to reaffirm that misguided belief, right? So here we go. They start doing their trials, and first 100 patients, oh my God, they were all occluding. 1 in 5 were occluding. People were getting emergency open heart surgery. And then with improved devices, it went down to only about 1 in 6 that were occluding, all right? And, you know, people were sort of ringing the bells for coronary stenting. It was dead before it started. However, that didn't last. And as you know, actually after that first half dozen studies, cardiology got very good at identifying those patients who were potentially appropriate for that therapy. And we also learned a lot about pharmacology, right? And we began to treat for platelet adhesion, right? White clots, we call them. And so that brings us back to the current day. And this is, you can't see this, but this is just the response of myself and some other people that are in a research group we put together about 10 years ago to these studies, all right? And of course, nobody listened. But let's take a look at these studies, right? So synthesis expansion, all right, was the trial that was run out of Italy. And, you know, as you begin to look at it, they randomized 362 patients to either IV TPA or endovascular. And as you look at the trial, you begin to see some profound differences, right? IV treatment was initiated more than an hour before endovascular treatment, okay? Now consider that for every 30 minutes that you delay interventional treatment, your outcome worsens by 10% as measured by modified Rankin at 90 days, okay? So again, this trial already put endovascular back by 20%, all right? So endovascular was destined to be 20% not as good potentially as IV TPA because they didn't get out of the gate at the same time. So here we go. And furthermore, when we looked at synthesis expansion, not everybody actually got treated, but they were included in the analysis. Only 56 had mechanical thrombolysis. And so if any of you were around for the Mercy Retrievers, right, or even the penumbra, you know, mostly the Mercy Retriever, that was kind of like a bunch of fishing line on the end of a little wire. And it was pretty ineffective, but it was the best thing we had. And that was part of this, all right? About 100 people just received intraarterial TPA, which is not tremendously effective. You know, you can see a bunch of patients didn't get treated at all. And again, this big group that just got intraarterial TPA rather than embolectomy, which is just not the way we treat patients now. And here, they don't know who had a large vessel occlusion or not before they went to the lab. So many of their patients didn't have occlusions that we would ever treat anyway. in spite of that, there was no difference in the safety profile. Now think about that, because the perception in the lay community and even amongst many of our colleagues in medicine and neurology, our intensivists, our ER docs, said, oh my God, you're going to the interventional suite. That's like a surgery. That's high risk. They're putting a thing in your brain. Would you rather have them put a thing in your brain and maybe you'll die, or wouldn't you rather just have TPA? Of course. But so what synthesis expansion really showed us is that interventional therapy is pretty darn safe. It's at least as safe as IV TPA, and maybe more so, because we can just look. I mean, there's no difference. So we took our patients back to the cath lab an hour later, and there was still no significant increase in intracranial hemorrhage relative to TPA, nor death rate. So in spite of subjecting the patients to IA therapy, many of whom were NIHs of 2, 3, 4, whom we typically wouldn't treat, without confirmation of an occlusion, it was pretty darn safe to go for thrombectomy. MR rescue. So this took patients within 8 hours of stroke onset with large vessel occlusion, and they went to MR perfusion. And then they were randomly assigned to endovascular or standard treatment. And the outcome was 90-day modified Rankin. So again, no real difference, all right? The MRS wasn't different. And the penumbral pattern in the analysis of all the data did not have an impact on outcome regardless of treatment modality. Now, one of the problems is that the mean time from stroke onset to initiation of therapy was over 6 hours, all right? And so if you come to our place and you're 6 hours out, unless you have a compelling perfusion study, we wouldn't start a therapy without knowing that you had salvageable brain. But the other thing is that the recanalization rate with endovascular therapy in this study was horrible. They only had a 27% recanalization rate measured by TICI 2B or 3. Now 3 is normal, okay? So TICI 3 just means that the flow in the brain is normal, all right? And 2B is as close to normal as you can get, okay? And so the 2B patients tend to actually typically get to full recanalization within about 24 hours. So again, MR rescue, for all of the good it did, it didn't seem to be a fair comparison because it wasn't utilizing modern techniques or therapies. It was still relying on things like ultrasonic catheters, the Mercy retriever, which for many of us never worked. I don't think I ever got an embolus out with it, and some other things. And think about this. Even in the group that got intravenous TPA, only 23% had a good outcome. So the results were terrible, and sort of incited a treatment nihilism in some of my referring docs. Now, having said that, and all I'm going to say about this busy slide is ignore it, but what I would really say is that there really was horrible technical embolectomy in the MR rescue trial. Historically, amongst the worst recanalization record of any trial we've ever seen, and essentially equal to some of the first trials, all right? So MR rescue was kind of like going back to 1977 coronary angioplasty in terms of technical efficiency. Again, in this case, what if you did get recanalized? So when we analyzed the data of the patients from MR rescue who actually were recanalized fully or partially, they did really well. Well, they didn't do really well, but they did better. And you can see 90 days, reperfusion. There's a statistically significant difference between the modified Rankin score of those who were and those who weren't. And on the partial side, same thing. Statistically significant difference for those who were recanalized versus those who weren't. And you can appreciate the difference in total infarct volume of about 20 cc's versus 60, and 9 versus 70, all right? So apples to apples, endovascular seemed to not be too bad, even in MR rescue. IMS-3, the trial that seemed to go on for most of my professional life, and these guys too, your whole fellowship and on. 900 patients assigned in a 2-to-1 ratio to a combination of IV TPA and intraarterial therapy versus IV TPA alone. The measurement, good outcome, was 0 to 2 modified Rankin at 90 days. And the study was stopped early because there was no way after 656 patients that they would have ever been able to achieve a difference between the two groups based on what had happened, meaning the two therapies were equal. But what happened in IMS-3? Again, it seemed like a good idea at the time it started, but the study bore no relationship to current therapy by the time it was over, because fewer than half the patients actually got a CTA or an MRA. So they don't know who had an occlusion or who didn't most of the time. More than half the patients were an unknown entity until the time they hit the cath lab. And the group that we're really interested in from an interventional perspective is that group. We want to know if they have an occlusion or not. I don't want to take them back to the cath lab if they don't have an occlusion. So, and in fact, of those 300 patients, 80 of them didn't have a lesion we could treat. They either didn't have a lesion or it was so distal and so small that there was nothing to do. And that was confirmed by the core lab. So, what else? Well, it really took them a long time to get into the cath lab in IMS-3. I'm not sure what they were doing. Couple hours. And the recanalization rate was horrible once again, 40%. Now, our recent trials with devices, we have 75 to over 90% recanalization rates with our devices, whether it be Penumbra, Trevo, or Swift, all of which were shown in prospective trials to have excellent recanalization rates. And all of our prospective studies that came out in the New England Journal have horrible recanalization rates that are comparable to the historical lows that we had with first-generation devices. So what good came of IMS-3? Well, again, in spite of not giving a full dose of TPA to the patients and taking them to the cath lab, sometimes without evidence of an occlusion, the endovascular group had no increase in the death rate or rate of symptomatic intracranial hemorrhage. So once again, we actually showed that for some of the sickest of the sick patients, we can take them to the cath lab and it is no more risky than giving them TPA alone, okay? And many of these trips to the cath lab, as you know, are with TPA on board plus a surgical procedure. And so I would submit that our interventional colleagues are doing such a great job in the cath lab that with medical therapy and surgical therapy, their complication rates are no different than medical therapy alone. But I'm biased, all right? So, but I'm right. Anyway, I believe I'm right, of course. So my wife says, you know, she goes, God, you're such a surgeon. Occasionally wrong, but never in doubt. And I say, yeah, I know. Anyway, so what do we know? Well, look at this, all right? So these bars show modified Rankin score at 90 days in the IMS trial for the patients who were documented to have large vessel occlusion. So this is just the patients from IMS-3 that had a carotid occlusion, an M1 occlusion, or an A1 occlusion. And these are their modified Rankin scores. And gosh, look, it seems like when you get your clot taken out, you're much more likely to be absolutely fine or nearly absolutely fine or to have a minor focal deficit that requires a little bit of help than if you don't get that done. And in fact, that's significant at the 0.01 level, right? Absolutely. What else? Well, here are some of the things I was talking about, right? So these early studies, IMS-2, the Mercy trial, the multi-Mercy trial, even one of the initial Penumbra trials, horrible recanalization rates. First generation device recanalization rates, okay? Not current therapy. Reperfusion and outcome, okay? And so we talked about this before, right? TICI-3 is normal revascularization. TICI-2B is near normal. This is the IMS-3 data that said there was no difference, just pulling out the patients with a documented vessel occlusion. If you have a documented major vessel occlusion and we recanalize you, the likelihood is if we get to TICI-2B, likelihood is about 60% that you're going to have a good outcome. And it's even higher. It's 80% if we get you to normal perfusion with embolectomy. Okay? This is the IMS-3 data, prospective randomized controlled trial, just looking at actual occlusions, not washed out by all comers. So anyway, so here we are. This is Ali. You know, he believes he can do it. And you know what? And from an interventional perspective, I think we can too. And the good news is that while freezing my tail off at my kid's soccer game last Saturday, I got a text message about this trial, which had been presented in Turkey last Saturday, about 9 o'clock in the morning. And this is the multi-center randomized clinical trial of endovascular treatment for acute ischemic stroke in the Netherlands. Mr. Clean, I love it. So, open label, blinded assessment, had to be over 18, had to go to treatment within 6 hours, had to have an N8 stroke scale of greater than 2, and it was IV versus IV plus intervention. So blinded assessments at 90 days. And what was really interesting is the government in the Netherlands sponsored the study, and they said, we will not pay you to do stroke embolectomy for anyone except as part of the study. And so they completed the study. And they did all the things you're supposed to do. And they put 233 patients in the endovascular group. About 80% of them got thrombectomy. All of them were assessed at 90 days. 267 went into the control group. 267 got TPA. 1 crossed over. I'm not sure what that was about, but they're praying. I would argue this probably occurred later in the trial when even the physicians thought that it wasn't the right thing to do. And 92% of the patients who got randomized to endovascular had a complete arterial occlusion, just like the patients we treat here, most of us. And they were, 2B, 50% at the end were 2B or 3. And interestingly enough, when they looked at 24 hours, the people who had got TPA only had a 32% recanalization rate. The people that got TPA and intervention were 80% recanalized. Apples to apples. And what was really amazing is that when they did the subgroup analysis, endovascular treatment was superior to IV TPA alone in every group, every cohort they looked at. And what really surprised me, it was most beneficial in the elderly. And that runs contrary to what we've believed for a long time, all right? We've believed that people over the age of 80 with comorbidities have a diminishing return with endovascular therapy, and sometimes we don't take them back. This will actually maybe change our approach to, gosh, maybe we should give them IV TPA and take them straight to the cath lab if they're going to have any chance of getting better, okay? And so, and the conclusion, and this is not in print yet, so this was embargoed last week. I did everything I could to get this, and then it came out on like Medscape Thursday night or something, and I'm like, ooh, time to do my talk. Anyway, so you can get this off Medscape. But anyway, the result is essentially that intervention is significantly better than just IV TPA, okay? But it's intervention plus IV TPA, all right? It's not intervention alone. So that makes me happy because, you know, I think it's...
There's a plan in everything, kid. And I love it when a plan comes together.
Yes, we love it when a plan comes together. So we've been planning on this for years. And unfortunately, like a lot of the stuff we do, you know, we think we're right, and then we have a prospective randomized trial that says we're not, all right? And at least in my neck of the woods in neurosurgery, of course, we had the ECIC bypass trial, you know. There's still neurosurgeons that believe that's the thing to do. But, you know, we had a trial that said it wasn't the right thing to do. Then we did it again, and it was wrong the second time. You know, an interventional stroke was in danger of heading in that same direction, but I think it's not going to for a couple of reasons, all right? I think that this study that was done in the Netherlands was an exceptionally well done study, not just because I agree with it, but that's part of it. But the reality is that it compared apples to apples for one of the first times, right? It compared people with an occlusion to other people with an occlusion getting two therapies, which I believe are complementary, all right? I believe that some of our patients need to have TPA and don't need to have intervention. And some of our patients need to have TPA and intervention, and some of our patients need to have intervention, all right? I've never believed that any of these therapies are exclusive or exclusionary. And I think that what we will find, very much like in cardiology, is that as we go through time, we will find out who should get what and when they should get it. And it's really about numbers, right? You don't go to the casino and play blackjack and win every hand, do you? And the reality is, stroke patients, we're playing the odds, okay? We want to give them the treatment which maximizes their benefit to have a good outcome at every stage of the process. And it's not always the same thing. And this is just a small sampling of what's going on currently. I think we're going to get a lot of information. And so I think that watermelon analogy changed it a little bit. It doesn't look quite so daunting now that we're growing up a bit. And I think we're on the right track finally. So thank you for your attention.